You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
All right, welcome back everybody to our second presentation of the morning. We have Dr. Roshini Abraham. Dr. Abraham received her PhD in immunology in 1996 and completed her postdoctoral fellowships in immunology, clinical immunology, and biochemistry at the Mayo Clinic. She was on faculty at the Mayo Clinic from 2002 to 2018. And since September 2018, she has been on the faculty at Nationwide Children's Hospital in Columbus, Ohio, and is a professor of clinical pathology at Ohio State University, Wexner College of Medicine. She's the Associate Chief of Academic Affairs and the founding director of the Diagnostic Immunology Laboratory and Program at Nationwide Children's. She is a fellow of the American Academy of Allergy, Asthma, and Immunology and the Clinical Immunology Society. She's a past president of the Clinical Immunology Society from 2017 to 2019, and she has published over 120 peer-reviewed articles, 21 book chapters, and over 150 abstracts. She will be speaking today on the diagnostic evaluation for inborn errors of immunity. Thank you, Dr. Abraham, for being here.
Thank you very much, Melissa. Good afternoon to everybody. I'm on East Coast time, so it's noon here. So what I'm going to endeavour to do in the hour that we have together is to go over some basic principles of diagnostic evaluation for the inborn errors of immunity. And I'm going to try to cover, a bit of everything because, as you can imagine, it's really vast. I sort of liken it to getting onto a bullet train or trying to hold an ocean in a teacup. It's hard to do justice in this very short amount of time, but I'll endeavour to give you a quick tour, and then certainly if you've got any questions, you can ask me now. You can also reach out later if something comes to mind. As you know, the International Union of Immunological The International Union of Immunological Societies, or the IUIS, has been doing a classification for what we used to call the primary immunodeficiencies and what we now call the inborn errors of immunity. It might be a bit of a misnomer, but anyway, that's what we have. And we've been doing it every other year. And now we've kind of started doing it pretty much almost every year. So the 2020 classification was released, and then in last year in 21, and then we had an interim update in 21, and then this June we had the 2022 update, and we stand at about 485 genes. And actually there are some genes that have been reported in the literature that are actually not included in this classification. So that's why I've said 485 genes plus, and I've put in purple up here the current number of genes in each of these 10 categories, and the ones in black down here are from the 2020 classification. And so what has been done is all these 485 genes have been sort of segregated into these 10 categories, depending on which component of the immune system they involve. So certainly, as you can see, this is a moving target, a bit hard for most clinicians to keep their finger on the pulse of in terms of the number of genes added, the variability in phenotypes, etc. And so I just want you to sort of keep your mind as a blank slate, so to speak, so that, we can sort of say, how does our thinking with regard to approaching diagnosis of a patient in 2022 go when we think of an inborn error of immunity? It doesn't mean you have to throw out everything you've learned or heard of in the past, but some things to consider with the plethora of new genetic defects and new clinical assays that are available, variability in phenotypes, etc. if one were to broadly, about a third of those 485 genes are genes associated with immune dysregulation, with autoimmunity, with atopy, with malignancy, lymphoproliferation. So we call them primary immune regulatory disorders, or PIRDs. And then we've got the infection susceptibility, and together they form our so-called inborn errors of immunity. And I'm saying so-called because not everything is a germline genetic predisposition. We can also have some somatic variants that cause immunological disease. And more to discuss, that's a separate topic. But basically, your patients would cluster with a predominant infection phenotype, or this, what we would call a PIRD phenotype, an immune dysregulation, whether it's autoimmunity, atopy, malignancy, lymphoproliferation. Then sometimes you may pick them up first by a laboratory anomaly, whether it's a selective IgA deficiency or a hypergam, that might be something you pick up, or a T-cell lymphopenia. And then some patients, of course, have syndromic disorders, whether it be ataxia, telangiectasia, or Nijmegen-Breaket syndrome, etc. There's more than the immune system involved. Some patients are picked up by family history, and others, of course, in this genomic era, are picked up, by straightforward genomic analysis, even before sometimes a differential diagnosis is formulated, which I don't think is the best way to go about things, but it happens nonetheless. Well, so this 460, I forgot to update, it should be now 485 plus. And so it's just every year we're adding anywhere from 20 to 30 new genes, that fit into one of those 10 buckets. And then we also have other confounders, like you might have inborn errors of immunity where you get predisposition to a particular pathogen or group of pathogens, like chronic mucocutaneous candidiasis, or herpes, or human papillomavirus infections, EBV infections, or mycobacterial infections. And so then, that list of genes that predispose to those kind of infections is also growing. We already briefly touched upon the issue of PIRDs and how that represents a growing number of genes within our overall list of inborn areas of immunity, not just autoimmunity, not just autoimmune cytopenias, but other organ-specific immunity, benign or malignant lymphoproliferation. And of course, if you've been paying attention to the latest issues of JACI, you've seen in the last couple of years, there have been some papers talking about atopy and allergic manifestations in the inborn errors of immunity. And then to confound everything, and why I said the inborn errors of immunity might be a misnomer, is the issue of somatic mosaicism. So somatic mosaicism can change or alter the phenotype. So you could have germline genetic defects, but then they could acquire mutations that cause what we call revertance or somatic revertance in subsets of cells. And Wiskott-Aldrich syndrome is one classic example. There's about 8% of somatic reversion that you can see in Wiskott. But we also have other somatic genes. The somatic genes means in subsets of cells not inherited through the germline. And for example, the TLR8 somatic variants that was published in Blood by Megan Cooper's group a year or two ago. And then the Vexus syndrome, with the somatic UBA1 variants published in adults in the New England Journal by Dan Kastner's group. So should we be calling things inborn errors? Because not everything is inborn. You could have, immunological diseases with somatic variants. And also then I should introduce two other concepts, incomplete penetrance and variable expressivity. Really, to talk about the genetics of the IAIs requires a separate talk. So I won't go too much into that, otherwise I won't cover everything I have to. So I'll just leave that out there, that can modulate your phenotype. Then we've got what we call the two-hit hypothesis. You could have a germline predisposition, but the phenotype is not manifested until you get hit with some sort of infection, like, for example, with X-linked lymphoproliferative disease type 1, due to mutations in the gene encoding the SAP protein. Those patients, go chug along till they get an EBV infection, and then the ball goes rolling downhill. And then our very last category in the IUIS table is table 10, which is the phenocopies of inborn errors of immunity. And these have no genetic disorders or could have somatic genetic variants in KRAS or NRAS associated with lymphoproliferative disease phenotypes, or autoantibodies to biologically relevant proteins like cytokines, like anti-interferon gamma antibody and mycobacterial disease, or anti-GM-CSF antibodies in the cardia, and so on. So I think for anybody who's in our field today, I don't think there'll be any disagreement in saying that we've evolved our whole concept of thinking about the IEIs, or the primary immunodeficiency dysregulation diseases, from the sort of one-dimensional linear, one gene, one phenotype kind of a model, to this total mess of things, which is like a good representation by Jackson Pollock's painting, because there's so many things that one has to take into account. There's so much variability in phenotype. There's gain of function, loss of function, somatic variance, incomplete penetrance, variable expressivity. So nothing is the same anymore. And you really have to keep a broad mind when you start seeing these sort of patients, and shed some of these preconceived notions that, a gene gives you a phenotype. But I think, again, just like with the evolution in our understanding, I think not many of us would dispute that making an early diagnosis is important, because once you have a genetic diagnosis, or you can correlate a particular clinical phenotype to a particular immunological and genetic diagnosis, then of course, you're able to then understand the etiology of that disease. You're able to do some prognostication. You can see what tools are there therapeutically for management of those patients. You can, do some prediction of risk factors that can modulate disease. You can, of course, counsel patients, because it's hard to do genetic counseling without a genetic diagnosis. And then, of course, we've got newborn screening for SCID, but we know that we pick up more than SCID from that newborn screening. And more importantly than anything, the shades of grey that I've been talking about can only come when you're able to have a genotype and phenotype, whether you're talking about, for example, STAT3, you can have loss of function with Job syndrome, hyper IgE syndrome. You can have gain of function with an autoimmune lymphoproliferative phenotype. Same thing with STAT1. STAT1 loss of function and Mendelian susceptibility to mycobacterial disease, STAT1 gain of function, susceptibility to chronic mucocutaneous candidiasis. So all of those sort of genotype-phenotype correlations can be made if you have a genetic diagnosis. And of course, the ultimate goal is to improve survival and outcomes. From a laboratory perspective, we do have a lot more tools available to us in the clinical laboratory, as well as, of course, the research laboratory, for making these sort of diagnoses, for evaluating these patients. Flow cytometry, which I'll touch upon, is certainly a key component, but we look at other soluble biomarkers, whether it be cytokines or other soluble proteins. We can do functional studies, of course, genetic studies. And then, of course, there are various studies that have not yet entered the clinical laboratory, because sometimes they're rare diseases and it's hard to justify the cost and the time for bringing it into the clinical laboratory. And so they remain in the research realm, but nonetheless useful to diagnose patients. So I'm going to start now, having given you that sort of quick overview. I'm going to start with talking about newborn screening for SCID. As you know, we're in our 12th year, well, almost going to be 13. We're a few months shy of 13 year of having started newborn screening for SCID in the United States. And we're about a little shy of 4 years when all 50 states in the country have been screening for newborn screening for SCID. And as all of you know, for SCID screening, we're looking at a piece of a T cell receptor DNA that we call TREC, or T cell receptor excision circle, that's generated as a byproduct of T cell receptor gene rearrangement. We make many different TRECs in the thymus during the process of TCR gene rearrangement, but we look only at a particular TREC when we think about newborn screening, and we call that the delta deletion TREC. It is sort of the penultimate event in T cell development in the thymus, and therefore it does not get too diluted by cell division in the thymus, because these TRECs are not part of the chromosomal DNA. So they sit as a little extra chromosomal fragment, and they get diluted by cell division. So you don't want to pick a TREC that's part of an early thymic event, because then it would already be quite diluted by the time the T cell comes out into peripheral circulation. So we look at this TCR delta deletion TREC. And of course, if it's normal, we don't do anything. If it's abnormal, then there are certain protocols followed by the newborn screening lab to make sure that that is a legitimate abnormal. And then it's sent, notified to the pediatrician, the immunologist, confirmatory testing is done in a specialized reference lab. Now, I will say at this point that there are a couple of documents, a couple of things in the works with regard to newborn screening for SCID. And one is the fact that all 50 states have heterogeneity in how they report and how, what units and how they report these TREC data, and also how they classify the data. Is there elevated risk, moderate risk, is there urgent, panic, different sorts of classification. And so there's no harmonization, no uniform way. So an immunologist in one state will know what that state might do, but if he or she goes to another state, they have to learn the ropes again in terms of how that state reports the TREC results and how they classify it, etc. So 2 documents. There'll be a document from the Clinical Laboratory Standards Institute on an update for newborn screening for TREC, and whether one should also look at CREC for severe B-cell immunodeficiencies. I chair that committee, and we hopefully should get that out within the next 6 months or so. And that offers a guide both to state screening labs and to clinicians. And the other effort that we're pursuing is what we call a newborn screening for SCID harmonization, reporting harmonization, terminology harmonization effort that is undergoing right now. And we're trying to come up with certain language that universally would be recognized by all immunologists, that if they see this urgent or this strong or panic or whatever, they know how to react to those results, as opposed to a result that is reported just as a low TREC, because we're segregating between SCID and other conditions for T-cell lymphopenia that might be picked up. So we've come up with some algorithms, and I'm just very quickly going to go over those with you because it will be in the newborn screening CLSI document I just mentioned. But the bottom line is we treat NICU preterm or low birth weight separately from term infants. We also treat low TREC differently from undetectable TREC. We have this kind of red lights, blinking sort of thing for an urgent, where you should think of SCID, or a severe T-cell defect like a complete DeGeorge, etc., and proceed very quickly to confirmatory. Whereas if it's a low TREC in the term infant, yes, you will proceed. But if it's a Friday evening at 5 o'clock, you can wait till Monday morning to get your confirmatory testing. And then, of course, if it's a preterm low birth weight, what do you do? Because here again, different states have different approaches to this process. And, we've also recommended what is the basic confirmatory flow cytometry test, not just looking at TBNK lymphocyte counts, but also looking at naive T cells, memory T cells, recent thymic emigrants, doing all of that together. So here's just an example for you to think about when we think about lymphocyte subset quantitation. This is a TBNK result. For those of you, some of you may be familiar with flow, some not. But basically, we are identifying lymphocytes by the CD45 marker. I'll clarify that CD45 is expressed on all leukocytes, but it is most abundant on lymphocytes compared to monocytes and granulocytes, which of course are more granular, so they sit up high over here in terms of side scatter. Monocytes are in between, lymphocytes are the least granular, so they sit way down here. And then, of course, some labs like my lab, my former lab at Mayo, my current lab here at Children's at NCH, we use what we call a purity marker, because you can see that if you didn't use that purity marker, you might bring some monocytes into your lymphocyte compartment and they will show up as NK cells, but they're not really NK cells, but they will look like pretend or pseudo NK cells. So by including CD14 to identify monocytes, we can kind of have a purity and say, oh, well, we're confident that these are lymphocytes. Then we look for T cells or non-T cells, and then we further segregate the T cells into CD4, CD8, and then B versus NK. And so if you've got, in addition to that, if you recall, I said, not just looking at the counts of the different lymphocyte subsets, but looking at naive and memory as well, because that is important. So as you would expect in a healthy neonate, you would have most of the cells that are naive, very few memory cells. And if you look at this CD31 positive, CD31 is what we call a marker for recent thymic emigrants or true naive T cells. It sort of indicates how recently they came out of the thymus, because you can have long-lived naive T cells in circulation that have undergone some cell division, but then they won't express 31, as you can see here. These are naive T cells, they're still RA positive, but they're 31 negative, whereas these up here are true recent thymic emigrants, and you'd expect most of the T cells in a healthy newborn to be like that. In that category, 31 positive. Now, this is a SCID, a T minus, B plus, NK plus SCID. And so, as you can imagine, first of all, you can see right away there's a lot of lymphopenia, because compared to the previous slide, you could see up here lots of lymphocytes, and here very few lymphocytes, and no big surprise. There's normal B and NK, but there's very few T cells, a few CD4s there, no CD8s, and if you then go and figure out what the genetic defect is, you'll understand, aha, this is a T minus, B plus, NK plus. And as you would expect, there's very poor thymic function because it is a defect in T cell development and maturation. So you really don't have much naive memory. You've got a few odd cells sitting here with a so-called transitional phenotype, but no recent thymic emigrants of any kind. So, this is a SCID or a severe T cell deficiency. Now, there's something that to think about, and that is that in 2014 in Jackie, there was the PIDTC, or the Primary Immunodeficiency Treatment Consortium, guidelines for diagnosis of SCID. And I'm just going to pull up something here, if I can, and I'm going to move it over so you can see. Please don't copy this or photograph this or anything, because it has been submitted to Jackie and it will be published, but it is not yet published. But in 2022, we have revised the diagnostic criteria for SCID, and we are saying that for typical SCID, we are no longer requiring PHA proliferation or measurement of T cell function by PHA proliferation. And I'll explain why in a second. So for typical SCID, you'll see there's no PHA proliferation. For leaky SCID or hypomorphic or partial loss of function or atypical SCID, you can have PHA proliferation if you wish to do that, or you can choose to skip that. It's no longer a mandatory criteria, whereas in the 2014, it was a mandatory criteria to look at PHA proliferation. So why are we changing our recommendations in 2022? The reason I'll explain in a second. So historically, I say that from our forefathers, we inherited this sort of thing, that it's a nice way to use a mitogen for global assessment of T cell function. So people have been ordering this test left, right, and center. Many times clinicians don't know the methodology by which this test is done, so they don't understand the limitations of the methodology and how it can affect the interpretation of the result. So people have been doing it historically. And that's partly because we didn't know any better. We didn't understand the biology. We didn't understand the impact of the methodology, but now we do. And so I'm actually working on a paper that will be submitted hopefully in the next month or so to Jackie, explaining using the PIDTC SCID protocol data as to how the methodology, whether you're using a radioactive based assay to measure the PHA proliferation or you're using a flow cytometry approach to measure, it can have a dramatic impact on your results, and clinicians need to be aware of that. So I consider the flow cytometry method to be the most sensitive, particularly in patients with lymphopenia, because you can actually visualize your cells. You can also specifically look at T cells. You don't have to look at bulk lymphocytes as you would with a radioactive method, you know, where you're blind to the whole process. In flow cytometry, you can actually look at what's going on. You can zoom in on the T cell compartment. So I sort of liken it to looking at the stars using a binoculars versus a telescope. You can understand that there is several orders of magnitude in improvement in resolution when you use a telescope. So this is background, healthy control. When you're not using any stimulant, you see just, you know, what is intrinsic, a few cells that may be proliferating intrinsically, but really very little background. Now you add PHA and you can contrast here, right? Just mentally capture an image. Now mentally capture this image. You've got lots of blasts. You've got an abundance of proliferating cells. And so you can look at the percentage of cells that are proliferating relative to either your total lymphocytes or your total T cells. This is it gives you an enhanced sensitivity in discriminating between normal and abnormal proliferation, particularly when you have severe T cell lymphopenia, as you would in most SCID patients. But the other thing I want you to keep in mind is, so I think it's important to know when you send out a test for this PHA proliferation, you need to know which lab are you sending it to, what method are they using to assess proliferation. If they're using a radioactive method, you may want to select a lab that uses a flow cytometry method that would give you more sensitivity, particularly in a patient with lymphopenia. But the other question to ask yourself is, what am I really gaining by doing this PHA proliferation? PHA, as you know, is a lectin, and it binds glycoproteins on the T cell receptor. So it doesn't bind the T cell receptor like a normal antigen would. So it really cross-links T cell receptors by binding to sugar residues in proteins on the T cell receptor, and it activates T cells that way. That is not physiologically, that's not how T cells are activated in our body, but we have used this historically because 50 years ago, we didn't understand much about T cell function, T cell activation. We saw that this could be used as a global T cell stimulant, so we did it, and we've been passing that baton down generation after generation to new people, new trainees, telling them, oh, you can order PHA proliferation to assess T cell function. First of all, T cell function is very nuanced. Proliferation is just one aspect. Cytokine production, expression of activation markers, all of those contribute to T cell function. So if you're using proliferation, remember that you're looking just at one facet of T cell function. You're not looking at it in a global perspective. And secondly, you're using a very artificial system to ascertain T cell function, because that is not how T cells are activated in the body. And if anything, you would be better off using like an anti-CD3 antibody and anti-CD28 antibody to cross-link the CD3 and CD28 receptors on the T cell, because that is what happens physiologically when T cells are activated in the body. So again, think about, is this physiological? How representative is this? What can I say about the patient's T cell function if I ordered this test and it is normal or it is abnormal? Is it really telling me a whole lot, or am I thinking that it's telling me something and I'm drawing some conclusions which may not be entirely correct? And then the last thing, as I mentioned, is the methodology is important, because if you use a methodology with less sensitivity, you might get a report saying diminished T cell function or to PHA, and you think, oh my gosh, this patient has low T cell function to PHA, but you might not realize that that patient may have normal T cell function, and it's just a matter of T cell dilution because of T cell lymphopenia. So I'll get off that particular soapbox. I've become quite passionate about this PHA proliferation these days, because I think people overuse it and overinterpret it. And so I hope at least in the next generation of trainees and next generation of immunologists, we don't send them out into the world with the same erroneous information. Okay, I'm going to switch now from T to B cells. If you've got any questions, you can interrupt me, but I'll just move on in the interest of time. So we're talking about the adaptive immune system. We talked about T cells. I'm not getting into any basic biology because time does not permit me. So I'm just sort of, trying to hit some key diagnostic points rather than sort of going sort of systematically about how these responses develop and evolve. So we use vaccine antibody responses as a surrogate to assess B cell function. And when we look at things like diphtheria, tetanus antibodies, we're also indirectly assessing T cell function, because we know that for the protein antigens, T cells have to give B cell help to get antibodies. So the kind of antigens that our B cells would recognize and mount an antibody response to can be divided broadly into T-dependent or T-independent. And most protein antigens would fall into the former category of T-dependent. But in the T-independent, we have different types of T-independent antigens. So things like lipopolysaccharide that are present in gram-negative bacteria that you might see in a gram-negative sepsis, for example, would stimulate a T-independent type 1 response. Whereas things like pneumococcal polysaccharide, your Pneumovax, or your meningococcal polysaccharide vaccine, they're T-independent type 2 responses, because they've got this repetitive units with your polysaccharides. And then we've got a third category, which is fairly new, where the antigen is usually bloodborne or gut bacteria, and we call them T-independent type 3 antigens. Now, very quickly, let's see, very quickly while I'm on this slide, I'll just point out a couple of things. One is to make antibodies to protein antigens, which require T cell help. You have to form a germinal center. You need the help of CD4 T cells that we call follicular helper T cells. And then, of course, you're improving the affinity of your immunoglobulin molecule, which is also your B cell receptor, because it's sort of like buying a pair of trousers in the store. It's really not tailored to your body. So you buy it and you might then take it to a tailor and have it, nipped and tucked to fit you better. So somatic hypermutation is that process of nipping and tucking to make a high affinity immunoglobulin molecular B cell receptor. And then, of course, you've got the isotype class switching, because you need to make different isotypes, IgG, IgA, IgE, etc., because they serve particular functions, right? So mucosal immunity, IgA, is very important. Antibody responses to allergens or parasites, etc. IgE antibodies are important. And then, of course, formation of memory and long-lived plasma cells. The thing to keep in mind with regard to the pneumococcal polysaccharide, which is another kind of sore spot with me, is that we now recognize, about 10 years ago, we didn't understand how you could make IgG antibodies to pneumococcal polysaccharide, because it was considered a T-independent type 2 antigen. So clearly you don't have T cell help. Then how are you making IgG? Because it was historically thought that you need T cells producing cytokines to make B cells switch to IgG, IgA, etc. And we do make IgG, IgA pneumococcal antibodies. And so in 2012, there was a discovery by Andrea Cerruti, etc., who showed that there are actually neutrophils in the marginal zone of the lymphoid follicles that produce cytokines that enable isotype class switching. And that was quite a paradigm shift in immunology. Who ever thought that neutrophils would be important in helping B cells produce antibodies? So now they're called B helper neutrophils. In the marginal zone of the lymphoid follicle, that's where these B cells that produce antibodies to T-independent type 2 antigens develop. So something to keep in mind as to why we make IgG and IgA antibodies to T-independent antigens. Secondly, interpretation of pneumococcal antibodies, that's a whole other discussion. But I personally think the value of that is diminishing as we're getting more and more, we're getting 18-valent, 20-valent protein conjugate pneumococcal vaccines. I don't know what purpose it serves, and we don't have any sort of unified consensus interpretation of pneumococcal antibody responses. So each group of clinicians does what he or she wants. And so I think it's just all over the place, and I really don't know what value. Again, it's one of those historical things we're handed down when we evaluate immunodeficiency patients, whether we're doing PHA proliferation, pneumococcal antibody responses, we pass this very faithfully down generation to generation, but not really helping people understand the immunological concepts of biology and whether it means what we think it means. So that's my very quick spiel on B cells. And now we'll come to NK cells. NK cells are lymphocytes, obviously, but they straddle that gray zone between adaptive and innate immunity because they have these preformed receptors. We have two flavors of NK cells in our circulation. 90% of them are what we call CD56 dim, CD16 bright cytotoxic NK cells. As you can see, they've got a lot of cytotoxic granules and they're ready to kill. And then about 10% of our NK cells in blood are what we call 56 bright, 16 dim or negative cytokine producing NK cells or immature NK cells. And they're much less effective, they're much less effective at cytotoxic function, but very good at cytokine production. Now, NK cells get activated quite differently from T and B cells. They get involved through a process, activated through a process we call licensing. And that is they've got a bunch of receptors on their cell surface. There are different flavors of those receptors. Some of them activate NK cells, some of them exert an inhibitory function. And so these recognize MHC class 1 on the target cell. And when it recognizes MHC class 1, it tells the NK cell, don't kill this cell. We call that licensing. On the other hand, if there's a virally infected cell or a tumor cell, they downregulate MHC in an effort to try and escape the immune system. But the NK cells are one step ahead of them. The inhibitory receptor can no longer recognize an MHC class 1 because either the virus or the tumor has downregulated it, and the NK cell knows, aha, I need to kill this because I don't see my ligand that tells my inhibitory receptor I need to block this. So we call that NK cell licensing, and that is the that's the principle behind the NK cytotoxicity assays. Now, I'll tell you that many people still order NK cytotoxicity assays for evaluation of HLH or recurrent herpes virus infections. I can tell you that it's not a very useful test because it's very labile. There's a lot of biological variability, and particularly with ship samples, so it doesn't mean a whole lot. So nowadays, people prefer to use what we call the degranulation or CD107 assay for HLH diagnosis, because these cytotoxic granules inside NK and CD8 T cells have this protein, have a cluster of proteins and a membrane around that. This is the granule membrane, and this sits inside the cell, right? It's not the cell membrane. So the CD107 is expressed on that. When that T cell or NK cell gets activated, this whole kit and caboodle starts moving to the cell membrane. And when you have HLH, you have genetic defects in a number of these proteins that polarize these granules, because these things have to move to the cell membrane and then they merge with the cell membrane. So what was once previously intracellular now becomes apparent on the cell surface, and you can use flow cytometry to identify this process of degranulation. These granules have to come to the cell surface before they can discharge their contents. I don't use guns or anything, but I think in this context, a gun is an analogy where you've got your bullets in your chamber, you cock the gun, and then only can you fire. So again, the perforin, everything is sitting in here. You have to come to the cell membrane, then you can discharge your perforin bullets, but we can also then use that as a surrogate marker for activation of NK or CD8 T cells. Okay, so that's our adaptive and, the cusp of adaptive innate, which was NK cells. And now let's move fully into the innate immune system and talk about neutrophil killing. We've got three primary mechanisms by which neutrophils exert their immune function. We use the NADPH oxidase activity, or the respiratory burst, to kill. There are several other proteases inside neutrophils that can kill. And then we have what we call the neutrophil extracellular traps, or nets, which are extrusions of DNA that sort of act to extruded outside the cell and can capture antigens or bacteria and bring them back in for killing. So this is sort of what NETs looks like. I'm not going to focus on this phenomenon that we call netosis. I'm just going to focus on this NADPH oxidase, or the respiratory burst. So these are the different granules that we have in neutrophils, and there are certain genetic defects that can cause specific granule deficiency. And we're, as I mentioned, particularly interested in the NADPH oxidase, because when those proteins are activated, they can then produce hydrogen peroxide with the help of myeloperoxidase and hypohalous acid, which can help neutralize and kill pathogens. So there are five molecules or five proteins that form part of that NADPH oxidase complex. We call them FOX proteins, or phagocyte oxidative burst proteins. And we've got one glycosylated version, that's the GP91 FOX. Then this is associated with X-linked chronic granulomatous disease. And these other four, 1, 2, 3, 4 are associated with autosomal recessive chronic granulomatous disease. And then, of course, this is RAC2, which is associated with RAC2 deficiency. RAC2 loss of function gives you a neutrophil defect. RAC2 gain of function causes T-cell lymphopenia or a CVID-like defect. We're not going to talk about RAC2 defects today. But I do want you to think about the neutrophil oxidative burst and used for diagnosis of chronic granulomatous disease. People think that this is a relatively easy assay to interpret, but I can tell you from personal experience, it's probably one of the most misinterpreted laboratory tests. If you have a lab or a pathologist or an immunologist who is not reviewing a lot of this, they can completely misinterpret, because there are different patterns that you can see, and I just want you to get an appreciation for that. And when you go out in practice, or even when you're training and you order this test, it's helpful for you to request the performing lab to send you the flow data so that you can review it as well and make sure that it's being interpreted correctly. So typically what we do is we use a compound called dihydrorhodamine 1,2,3, which is non-fluorescent, and we label the cells with that, and we activate the neutrophils with a non-specific stimulus, which is typically PMA or formyl myristate acetate. It's another lectin similar to PHA. So when you have neutrophils at baseline in a resting state, their NADPH oxidase activity is not turned on, so you won't have oxidative burst, and the DHR is non-fluorescent. The moment you activate those neutrophils and you get that NADPH oxidase pathway into action, they'll produce these superoxide anions, which will then convert that non-fluorescent dihydrorhodamine 1,2,3 to an oxidated form of that compound, which is fluorescent. It emits a green fluorescence, and you can pick that up. So you can see that there's a complete shift. The red and the green are non-overlapping. I hope none of you are colorblind. They're completely non-overlapping, and there's a good shift showing you a nice, robust NADPH oxidase activity. Now, if you look here, this is a classic or typical X-linked CGD with complete loss of function, where you see the red and the green are completely superimposed or overlapping. That means even on stimulation, the NADPH oxidase, because that GP91 FOX is not working, that pathway is not working at all, and so you don't have any oxidation of the dihydrorhodamine 1,2,3 to form this oxidized molecule that is fluorescent. If you've got autosomal recessive CGD due to NCF1 or P47 FOX mutations, what you see is this sort of broad peak, some of it overlapping with the unstimulated, and then some of it sort of showing you some oxidative burst, but several log orders of magnitude lower than you would see in a healthy control. That pattern is quite different from what you would see with X-linked CGD, but it's similar between P67 FOX and P47 FOX. And so when you see this pattern, you typically think of autosomal recessive CGD. Now, this pattern can be seen in three contexts. One, it can be seen with hypomorphic or partial loss of function X-linked CGD, which is actually this case here. This is a 7-year-old boy with Burkholderia pneumonia who has a partial loss of function CYBB mutation. So you can see he looks quite different from that because he's got a partial loss of function mutation. So he's got some oxidative burst, but not normal. But this pattern can be seen in two settings: P40 FOX CGD, which people often consider is an atypical CGD because it doesn't clinically look like the other CGDs, and complete myeloperoxidase deficiency looks like this. So immediately what the lab is supposed to do when they see this pattern is to write something in the report that alerts the clinician that says, I see an abnormal result. It is not consistent with X-linked CGD. It's not consistent with these types of autosomal recessive CGD. The two possibilities, or the three possibilities, are a partial loss of function X-linked, or a complete myeloperoxidase deficiency, or a P40 FOX. And your management would be very different for complete myeloperoxidase as it would be for other forms of CGD. The other thing with X-linked CGD is the process of lionization or X-linked inactivation, X chromosome inactivation. And female carriers, as you know, can have two populations, right? Because they've got two chromosomes, one bad, one good. And so they'll have two populations for oxidative burst. And that can change with age. Some people have seen an age-related increase in abnormal X chromosome inactivation, and some people say that there is no age-related association. But this is a 65-year-old woman who was and is a carrier for X-linked CGD. She has a son who is affected. But she, by age of 65, had almost 100% skewed lionization, as a result of which she got Burkholderia pneumonia. So she became clinically symptomatic as a result of complete inactivation of her good X chromosome, leaving her with the mutant X chromosome and therefore no oxidative burst. The other thing to keep in mind is the quality of the sample definitely can affect your results. So this is what a good quality sample, your neutrophils are nice, healthy, and good shape, you get a good, clean result. Here's a good, normal individual, a healthy individual. The neutrophils have been sitting around a little too long. You can see several of them are dead. So you have very few viable neutrophils. As a result, you get this kind of double peak. And this is very commonly misinterpreted by pathologists or any lab director who hasn't seen enough of these. And it can totally lead the clinician on a wild goose chase. This is a perfectly healthy individual. It's just a poor quality sample giving you this result. And so people can say all sorts of rubbish, that it's, carrier, two populations, this, that, and the other. Or they may ask if the patient had a transplant and is chimeric and all this, but the long and short of it is a poor quality sample. This very same test that is used for diagnosis can also be used for monitoring of patients post-transplant for CGD or post-gene therapy, where you can use it to look for disease-specific chimerism. In other words, you can look for reconstitution of proper, normally functioning neutrophils. And the amount of oxidase activity can be surmised from the fluorescence intensity. And there's a 2010 paper from the NIH group that says that the amount of NADPH oxidase activity can correlate with survival. So it's important not to just look at a lab where they send you the percent of neutrophils that show oxidative burst. You need to look for a stimulation index or a median fluorescence intensity. And if you don't have that, you should call the lab and ask for that information. This is just to show you how the P40 FOX looks very different from these other types of CGD. The other thing is that my lab, we can also do flow cytometry to look at specific proteins in the NADPH oxidase pathway. And this is so within a day, we can tell you what the genetic defect might be, even before you get any results of genetic testing, because this is a healthy control, by the way, based on the flow cytometry and whether the protein is present or absent, we can tell you. And this is particularly relevant for the NCF1 gene or the P47 FOX, because that gene has two pseudogenes, and very few labs offer genetic testing for that gene. And even if they do, they only look at the most common deletion. So you can miss a patient who has a different mutation in that gene, but this particular assay can pick up those patients. And then now we've got a sixth defect associated with CGD due to mutations in the gene CYBC1 encoding this protein EROS. This protein EROS is very important for this GP91 FOX functioning. And so if you don't have that, you can wind up seeing reduced but not absent DHR activity to PMA. And this is the myeloperoxidase deficiency I mentioned to you. This is, healthy control, a shipping control, and here's the patient. You can see all the neutrophils show some NADPH oxidase function, but it is abnormal. And you can do a peripheral smear, a peripheral blood smear, and stain for MPO. And you can see that the patient and her brother has a little bit, but this patient doesn't have any. And this is the father. You can see lots of this brown staining showing myeloperoxidase. The last example I want to give you is the leukocyte adhesion deficiency. So we know that, the cells of our immune system, whether it's lymphocytes or the innate immune system, they've got to move. They can't just sit around in one place. They can't just hang around in blood, because they need to go into tissues, check things out there as well. And so these integrins are sort of the address, that tells them when to go and where to go and how to move. And so when you don't have proper expression of some of these integrins, you then wind up with an immunological phenotype. And leukocyte adhesion deficiency is caused by mutations in this beta-2 integrin encoding the CD18 gene. As you can see, it's expressed on all our cells, on lymphocytes, monocytes, and neutrophils. The red is an isotype control. The blue is the specific staining. And you can see nice expression in a healthy control of CD18 homodimers. And then the CD18 partners with other molecules like 11A, 11B to form these different types of integrins, MAC1, LFA1, etc., that have different roles in causing different immune cells to interact with each other as well as to move around. So this is what a normal individual would look like. Everything looks hunky-dory. You don't see much 11B on lymphocytes, but you do see good expression of monos and grans. Here's a patient with leukocyte adhesion deficiency. You can see that the red and blue either overlap, or the blue is to the left of the red. It's even less than the isotype control. With the expression of 11B on granulocytes, you can have some residual expression even if you have a mutation in this gene. But this tells you that there's no expression of CD18, which is consistent with leukocyte adhesion deficiency type 1. And then the last thing I want to leave you with is the complement defects. This is a bit more challenging because not many labs offer complement testing, and also not much exposure in terms of how to interpret the data. But you can sort of broadly group the complement defects into those that give you susceptibility to bacterial infections, those that are associated with certain rheumatological manifestations. Then you've got your hereditary angioedema or acquired due to autoantibodies. And then the other category is your atypical HUS or thrombotic microangiopathy. This is a nice sort of graph that I took from this particular paper. I adapted it. And by the way, I'm happy to share these slides with you. I think those of you who are second-year fellows, this might be your second year of hearing this, and you may already have the slides. But if you do want the slides, do let me know, and I'm happy to share, because I understand it's difficult to memorize all of this at one go. And I don't have much time to sort of walk you through this pathway, but I've tried to create it in a way which is pretty self-explanatory. We've got these three major pathways, the classical, the alternate, and the lectin pathway. And so it sort of gives you a guideline of how to check what, when, under what circumstances. So I won't dwell on this unless somebody has some questions. The important thing to keep in mind is if you're ordering complement testing, you have to be very sure to communicate with the laboratory, because there's a lot of pre-analytical issues to consider. Complement gets activated very easily once you take it out of the body and even put it into a blood collection tube. Complement can get activated. So, the tubes have to be kept cold. The serum has to be, or plasma has to be taken immediately frozen and then shipped to whichever lab is doing it, etc., etc. So very important to consider this and communicate with your lab. The concept of genetic testing for PIDs, it's really a vast topic. There's a lot to cover, and I just want to leave you with the fact that, of course, we no longer do single gene sequencing. We're using panel or exome or genome with next generation sequencing. There are advantages and disadvantages to using this. I would also say that never use genetic testing as a surrogate for coming up with your own differential, because many times you'll come up with genes, variants in genes in your in vitro report, etc., that have no bearing on the patient's phenotype. So always keep a differential so that you know how to interpret when you get that genetic report back, and that you know when to select a targeted panel, when to select exome, when to go to genome. It's really a separate topic. I can send you a review article I've written on the topic if that would be of help to you. And this is an algorithm that I created for our own immunology clinic. I know it looks a bit busy and confusing, but I'm happy to share this with you so that you can sort of ponder it. But, we have different ways of how we treat an urgent, inpatient, critically ill patient versus somebody in the outpatient setting. And when would we choose a targeted panel? What genes are we considering on our differential diagnosis? Are they well represented on the targeted panel, or should we go to exome? What is the limitation of exome for our PID or inborn errors? We need to know our genes a bit, because don't think that exome is foolproof. It's far from. So then would we go to a genome in those individuals or things? When would we use a rapid genome? And at your center, I know that you've got rapid genome as well. So all of those things have to be considered. And then, when you get your report back, what do you do with that variance of uncertain significance? And that's actually really a separate lecture in and of itself. So I'll just leave you with this. I'm happy again to share this with you so that you can sort of go through this. And if you have questions, don't think that because we are confined to, don't think that we are confined to just today. You can email me if you've got any questions. But in a nutshell, we've try to very quickly go through some highlights of genetic testing for both the adaptive and innate immune systems. We have a lot of tools in the diagnostic lab, but I think clinicians need to have a better understanding of, some of the limitations and applications of those tools so that they can engage with the laboratory and not make assumptions that the people in the lab know what you are specifically looking for in a particular clinical context, and also sometimes interacting with them, offering clinical history can allow for better interpretation. And again, when it comes to things like PHA proliferation, pneumococcal antibodies, don't just take things because they're handed down to you by your attendings and so on, because now we do have better knowledge and understanding of biology. So try to apply some of the biological underpinnings to understand, what is this test telling me? What are the limitations of interpretation? What are the limitations of the methodology, etc. So I'll stop here. And I'm happy to answer any questions if you have any right now, or happy to correspond with anybody later.
Thank you, Dr. Abraham, for that wonderful overview. And it's a lot to cover, and I feel like you did an excellent job. And I particularly appreciated the discussion about PHA, because this actually came up in clinic yesterday with Dr. Rajay.
Wonderful. Well, I hope that paper will be out so by the end of the year or very early next year. I'm working on it right now, and so hopefully that'll give you some additional guidance as well as the revised 2022 PIDTC SCID diagnostic criteria.
Hi, Roshini. This is Nikita Rajay.
Hi, Nikita. Yeah,
always nice to hear from you. This was an excellent talk. Thank you so much.
You're welcome.
A quick question about the pneumococcal titers. Do you see Salmonella typhi titers replacing, or any other testing that we could use for antibody deficiencies?
Right, it's a very good question, Nikita. As you know, only one lab at the moment offers the testing to the Salmonella typhi, and that's the lab at MCW. And it hasn't, taken a lot of traction elsewhere. There are people who send the testing there. And as the new 20-valent for pneumococcal vaccine, the protein conjugate emerges, and the sort of lack of consensus in the interpretation of the pneumococcal antibodies, there are people who are using the Salmonella typhi. And then, of course, in the beginning, when COVID was still new and it wasn't in IVIG products and we weren't vaccinated and all that, in 2020, for a short while, there were some people using, COVID as a neoantigen. And then there are some people who still use rabies vaccine in the United States as a neoantigen, some people who use the tick-borne encephalitis virus in Europe as a neoantigen. So lots of people do lots of different things. Excuse me. So we haven't really come up with a consensus. I mean, there are people using Salmonella typhi for sure, but I can't say that it has universally replaced pneumococcal.
Sure.
People are still muddling their way through the pneumococcal thing. And as I told you, different people are, using different things, but none of the others have actually gained a stronghold and a foothold and taken over from pneumococcal. And so the way the pneumococcal data is interpreted now, Nikita, I really am very dubious about, how it's being used for the diagnosis of humoral immunodeficiency.
Sure.
Let me just put it that way. We don't have consensus. I don't think we'll ever come to consensus, and I think the new vaccines will outstrip our ability to reach consensus on the polysaccharide. And so I would just, say we ought to be cautious. Don't let it be another PHA type of thing, you know what I mean? Where we impute certain interpretive attributes to it, and when it probably doesn't have that, and we might be over-interpreting or overusing a test or being over-reliant on a particular test to make the diagnosis, when that test may have relatively low diagnostic sensitivity or specificity.
That's very helpful. Thank you so much. And I agree with Dr. Anderson. This just came up yesterday about PHA and antigen assay. And so we really appreciate that input and your perspective on that.
Oh, absolutely, Nikita. Anytime. Good to talk to you.
Same here.
Okay, well, thank you, everybody. Have a good afternoon.
Thank you, Dr. Abraham.
Okay, bye.
All right, everyone, that concludes Conferences Online and Allergy for the day. Hope everyone has a great day.